experts.
Okay.
Yes.
So thank you very much for the opportunity of being able to make an oral submission. I did make a written submission. Just to clarify, I'm not a complainant, in case anybody misunderstands my presence here. I'm really only here as an aid to the panel in terms of my experience that I've had in representing several healthcare providers in their investigations and inquiries with medical schemes. So in terms of my qualifications, I am an advocate at the Johannesburg Bar, but prior to that, I actually qualified as a pharmacist. I'm still registered as a pharmacist. And in my experience in the healthcare sector, I was able to, in fact, fulfill roles as a pharmacist, as well as having worked in pharmaceutical industry. And then in the latter part of my career as a pharmacist, I actually spent just under 10 years in a major healthcare funder. So I do have somewhat of an inside track and an understanding of the funding business and managed care.
What was your role in the health? Did you say healthcare funder?
Yes, so I actually was employed by an administrator, and my role there was as a risk manager. In that function, I actually did various things. So I managed a low-income plan. So I risk managed a low-income plan, as well as medical devices and pharmaceuticals. So in light of the fact that I have the experience, many healthcare providers, when they found themselves in difficulty with medical schemes or administrators, approached me to actually assist them in their investigations or in their consultations. My colleague who's with me today, Nabila Mullah, is one of my instructing attorneys. There are others as well, but I think for the sake of just trying to keep this as smooth as possible, I actually just asked her to assist me if any specific queries come up about any of our specific clients. So I made this submission to the panel in my personal capacity, as I mentioned and explained in the submission itself. It is based on a collective experience spanning various schemes, administrators, and various types of healthcare providers. I'll provide a little bit more insight into the various disciplines that I represented. And I'm hoping that, in fact, through my not having been directly involved in these investigations, that I can actually give you a more objective and maybe to some extent slightly subjective assessment and analysis of those investigations. So to give you an idea of some of the demographics of the professionals represented, in terms of gender mix, it's almost 50-50, 47% male, 53% female. In terms of racial mix, whites, and because the specific inquiry, this would not be something I would normally collate, but it's because the inquiry is around discrimination. I have included that information. About 13.3% of the healthcare professionals were white, and for the remainder, they were a mixture of Black, Indian, and colored. In terms of the disciplines that I represented, specialists made up about 27% of the clients, general practitioners 20%, allied healthcare professionals 46%, and pharmacists 7%. The allied health professionals actually were a whole myriad of them, but in my presentation you'll see there seems to be a trend. So from time to time there's an investigation into a specific area of healthcare, and so there was a significant number of clinical technologists, in fact, that were actually part of my client base over this period of time. So I just wanted to clarify that there actually are different types of investigations. And I think you had Dr. Audrey Koch present to you. And the emphasis in Dr. Audrey Koch's presentation was, in fact, on a very specific type of investigation. I've included in the pack, which you'll receive shortly, an idea of the type of analysis that's done when, in fact, it's a quality assessment, which I will refer to in this instance as a risk management intervention. It's a very different investigation to a forensics investigation. And now let me talk about the forensic investigation firstly, because that actually forms the bulk of the ones that I was involved in. Only two of the investigations that I was involved in were actually risk management. For the remainder, they were all forensics. And maybe I'll start off with the risk management investigation. A risk management investigation is almost exclusively for consulting disciplines. Now, just to explain, a consulting discipline.
Sorry.
Go ahead. Go.
I just wanted to understand the difference between a risk management investigation and a forensic investigation.
So firstly, it emanates from different parts of the healthcare funder. There's a forensics department that handles the forensics investigation, whereas the risk management investigations are born out of the risk management function of an administrator or managed care entity. So it actually becomes a subset of all the other risk management interventions that they're involved in. So contracting, for example, or setting up of networks are all part of risk management interventions, and this form of analysis is born out of the risk management function. And it is a slightly different, and I've included in the information that you're going to receive an example, which I've redacted, of a profile that emanates from risk management interventions.
Just to ask a further question about this, would you say, is it all the administrators or schemes that do this, or are you talking to a select few, because this is the first time we're hearing this distinction?
I would think it's a select few. And in particular, one of the major administrators is the one that actually has this specific risk management intervention or analysis that they undertake.
Which administrator is that?
It's Discovery Health. And in fact, Dr. Audrey Cock in her presentation spoke extensively, in fact, about the risk management investigations as opposed to the forensics ones.
So is your evidence then, rather that in relation to discovery, there's this distinction between forensic investigations and risk management investigations?
Correct. I'd have to limit that to what my factual knowledge is, and that is that at discovery there are two different and distinct ones.
And the risk management investigation wouldn't emerge from the basis of a complaint to the administrator?
No, it wouldn't.
And further risk management investigations, do they result in clawbacks in terms of Section 59?
So they do, but in fact, that is almost always a very last resort. And this is a very important distinction because, in fact, in a risk management intervention, where the manner in which they classify an outlier is very different to the manner in which a forensics investigation will classify an outlier. And the major factor, the distinguishing factor, is that when a risk management analysis is done, a significant amount of the time is spent very robust analytics in trying to understand a practice demographic and distinction. So they'll take into account things like risk adjustment. Has this particular practice got primarily geriatric or pediatric patients? And they make adjustments for those things. And the parameters, the outcomes that they look for are quite distinct from a forensics investigation.
So what data underlies the risk management assessment?
It's primarily, it emanates, the starting point would always be the coding, but what they take into account would be all the costs related to a specific event. And this is actually one core factor that I need to explain.
I'm going to slow you down, sorry, because you're going to lose that, or certainly lose me quickly. A risk management investigation, is it directed at a particular practice only?
It's directed at a discipline level. So, for example, they would say, let's analyze all physicians. And all physician practices will be analyzed and they'll be plotted on a scatter graph. And in fact, what they'll only focus on are the ones that are distinctly outlier practices, where in fact the costs related to that particular practice are significantly higher than all other practices or similar practices. So there's a significant amount of risk adjustment. They do trimming, so they take out all the very low costs, very high costs, and they only analyze what they honestly believe are in fact relevant parameters. If I can just take a minute to explain. So if we look at a physician risk management investigation, what they would do is they would take a specific practice and they would look at their inpatient and outpatient costs total per episode. They'd adjust that based on the coding. And they would take into account things like comorbidities of patients. They would take into account other underlying risk factors. So there's a very robust risk adjustment that takes place before they actually classify a practice as an outlier practice. But what is important is that when there's an admission, all costs relating to that admission will default to the primary or the admitting doctor. So if a patient was admitted through casualty and they presented with a headache and they were allocated to a specific physician, but the physician felt that what this patient needed was in fact a neurologist to come in and assist with the investigations, all the neurologist's costs would also be attributed to the physician as part of their total cost per episode. All MRI, CT scans, pathology, if they called in a physiotherapist, if they called in a clinic, all of the costs related to that admission would be attributed to the primary doctor in that admission. And that's why this is quite a different type of investigation to a forensics investigation, where it's looked at almost in a more two-dimensional way, where you look only at the practice type from the numbering system, and you look at codes, and you look at the frequency of use of codes, as opposed to a total cost per event. In fact, what's interesting, and you'll see in the example that I've given you of a risk management intervention, is they also take into account things like ancillary factors about quality measurement. So readmission rates, they take into account if it's diabetic patients, what are the HbA1c results from that particular patient. So it is a more robust and a comprehensive analysis as opposed to what you get from a forensics investigation.
So how did you know that Dr. Kok, if I remember, she was represented the consulting physicians, how do you know that she was presenting in relation to risk management investigations?
Primarily from the information that she was sharing with the panel, as well as the fact that she actually is on the advisory panel, or was at the time on the advisory panel.
But what do you mean the type of information? What information made it appear to be a risk management
She spoke about John Hopkins, and she spoke about how it was actually modeled on the John Hopkins. And I know as a fact that that was actually based primarily for the risk management. And in fact, there were various other things that she spoke about. The fact that, in fact, the foundation or her organization was involved in the interventions in forms of counseling with providers as well leads me to believe that that was primarily what she was talking about was, in fact, risk management interventions. Because that
Can I just ask you, to make sure that I understand the distinction? Because a scheme will argue that a forensic investigation is also risk management, because they are trying to anticipate risk, manage it, and if there's money lost, claw it back. So you could either have a scheme that says we've got two different procedures. One is risk management and the other is forensic, and they maybe draw a distinction. The other is you could look at it after the event and say, okay, well, this looks like it was a forensic and this looks like it was risk management. And so, but in other cases, the distinguishing line may not be clear. You may start an investigation as quote-unquote risk management. You realize that actually I need more facts, and therefore it must migrate into forensic. So what's unclear to me is, are these distinctions things that you have drawn yourself, or are these apparent from the policies of the schemes, or especially if they all ultimately lead to a Section 59 clawback?
So I can only talk from my personal experience. I was able to distinguish that by asking the specific question. Where does this investigation emanate from? Is it from the risk team, or is it from forensics? And in fact, when we go in with our providers into what is typically a forensics investigation, the one question I ask always, was there any risk adjustment done in this analysis? And the answer is always no. No risk adjustment is done. It's purely on the coding, and it's purely on the practice type. It's not where they take into account the factors relating to the patient. That may well come out in some of the defenses that the doctor puts forward, but it's not part of the analysis that's done by the forensics team.
So you would say that because it comes from the risk team, then it has the attributes of risk management. And because a different one comes from the forensic team, then it is a forensic investigation.
Correct, but I can also, your point is quite correct. Both actually are potentially risk management strategies.
Yes.
What I'm trying to create the distinction is in terms of the analysis that's done and in terms of the process that then follows. So I want to, even though they may both ultimately land up in a 59 clawback, what's really different about the two different types of investigations is the risk management intervention, the one that emanates from the risk management team, allows a practitioner to be counseled. There's a lot of, if we can use the legal term, performance management that would take place. They would consult with the practice on several occasions. They'll call them in and say, can we understand why your practice is different? Are you able to do this and that differently? And so there's a fair amount of counseling and almost remediation that takes place, as opposed to in the forensics investigation, where in fact, the ultimate goal is in fact a clawback. It's not about changing the manner in which the practice actually practices. So if I can just share with you one little thing about when the investigation emanates from the risk management department, and there are various interventions, including calling in specialists like Dr. Audrey Koch to assist the practice in trying to change and modify their behavior or the manner in which they treat patients. All of those are interventions. What happens, which I think is quite different, is that the practice is allowed the opportunity to look at where perhaps, even though the coding is used and cost is used, where the practice may be going wrong. So in terms of one particular practitioner that I was involved in, what they were not doing correctly was coding properly at the end of the event, so at the discharge point. So they were coding based on the initial assessment of the patient and not including, for example, the final diagnosis that the patient had. And that changed completely the outcome of that analysis. Because if the doctor codes again and properly codes for comorbidities, which is what the funder then eventually receives and tracks in terms of the analysis, that practice may well not be an outlier. Because when you take into account comorbidities, if you take into account other risk factors, that the way the practice manages that particular patient may well be in line with all other practices. So that by changing coding alone, or by refining or improving on the coding, that particular practice no longer was classified as an outlier practice. That type of opportunity does not exist when the intervention is purely forensics.
Yeah. Now, you see, that's part of the complication. That you could have these distinctions as rigid, or you could have them as fluid. And what we have heard on the evidence is that they are in fact fluid, because an investigation could commence as forensic, but it could migrate into risk management, and that is all a choice a scheme makes. Another investigation can start as risk management, but it could quickly turn into a forensic. And so that's why I wanted to know whether you were saying you've drawn these distinctions yourself. Alternatively, you are taking them from the schemes, that the schemes have separate and distinct policies. Because the evidence, certainly as I remember it, is that some investigators will take a more interventionist line. They'll say, well, let's try and help you. But another investigator will say, there's no point in helping you, let's just try and claw as much as we can. So I don't know where I mean, I see the point you're making, that a risk-based instrument is better because it's intended at improving behavior, whereas a forensic-based intervention is bad for the doctor because it's intended at punitive action. But I'm just not sure whether, as a modality of investigation, there is any basis to say that these are distinct practices, because there seems to be a lot of combination of these strategies.
So I can only share from my experience.
Sorry, Advocate, before you respond, in your response, can you also just clarify how, because one distinction, you see, when you get a letter from the administrator, from a forensic investigator, it says you've been identified as an outlier in the following respects. And that emerges from what we are told is a database and algorithm, a program that kicks out the outliers. And how is that different from how a complaint is initiated from a risk management perspective? Is there a different way in which the outlier is identified?
There is a completely different way in which the outlier is identified, and in fact...
I did not want to distract from the question
yes.
that the chair put to you, so if you can address both, thanks.
Okay, so it is possible that the one migrates from the other. I can only share with you from my experience, however. In my experience, the first letter that the provider receives is usually indicative of what type of investigation. So it'll always say the forensics team of that particular healthcare funder or administrator, if it came from a forensics department. In my experience, in the investigations that emanated from the risk management department, they were not presented with that type of letter. In fact, what I will show you when you get your pack is an example of what's presented to the provider when it's a risk management intervention. And the data sets are completely different. In fact, when it emanates from forensics, there's very little supporting documentation that goes with the invitation to meet. Whereas with the risk management intervention, there's a booklet, and it's I think about 30 pages of information about that particular practice and how that practice compares to the universe of practices. similar practices. So it's a far more robust analytical process, and I think that what's indicative is where it emanates from. And just to clarify, in our experience, none of them have actually migrated from the one area to the other. And I'm only talking about my experience. Where it starts out in forensics, it usually ends in forensics. If it starts out in the risk management department, it would end in the risk management department.
It seems to me that the risk management component doesn't relate to fraud, waste, and abuse.
So the only reason why I raise that is because, in fact, it's still deemed to be the outlier, and because what Dr. Audrey Cox specifically presented to the panel related primarily to the risk management intervention and does not apply necessarily to the forensics interventions.
I think my last question is, I'm just looking at Discovery's submission, because what's also troubling me about this is that it's not a distinction that Discovery itself draws. And they say they've refined their risk rating tool to be more effective at identifying potential fraud, waste, and abuse cases. So it does, I mean, I must be honest, the scheme has to explain this to us itself, if it's correct what you're saying.
I think it would be a very valid question to put to the scheme, and I think the documentation that I'm going to be showing you, in fact, is quite different when it's a forensics investigation versus a risk management intervention. And I'd like to also emphasize that when we ask to accompany a provider into a meeting, the one question I always put when the analytics are presented to us is, was there risk adjustment? And in every case there was a forensics investigation, we were told no.
So is the risk rating tool that Discovery uses, is it used in the risk management investigations?
It is used in the risk management intervention, but not necessarily, and I can't say categorically that it's never applied in the forensics investigation. But in the investigation that I've been involved in, when the question is put to the forensics department, was there any risk adjustment taken into account here, we are told categorically not.
So your evidence completely contradicts then what I've just read out to. Okay, we understand.
So my colleagues just reminded me that, in fact, where it's relevant, we've actually asked for the forensic department to include the specific people from risk management in our representations. So we've asked for the clinical coding departments, for example, for their representatives to be brought into our consultations. They're not ordinarily part of a forensics investigation. So I'm not going to go through the details unless you want me to, but why I distinguish between those two types of investigations. But I also want to just explain one important point under the forensics investigation. Oftentimes, the forensics investigations happen in waves, as I mentioned earlier. So they take disciplines and they investigate specific at a discipline level. But sometimes they also initiate it because of a tip-off or the probes. None of the investigations that I was involved in included the probes. So I really won't be able to answer any questions around whether there was entrapment or whether there were probes and what the mechanisms are of people going in there and, in fact, sort of in the clandestine way trying to uncover information about a practice. Most of them, a number of them actually did refer to tip-offs. And what's important, and I'll talk about this in terms of the procedural concerns that I have around investigations, is that when information is requested about those specific tip-offs, they never provided.
Is that why you use the word purportedly?
Yes.
You'll be telling us more about that.
I will. And then oftentimes the forensics ones are on practices where there's time-based. Again, another distinguishing factor in terms of the risk management investigations is that they primarily disciplines that are, as I mentioned earlier, consulting disciplines. I don't think the techniques have been refined enough to be able to do proper, robust analytics on practices that are more surgical-based or combination practices. So the majority of the ones where, in fact, there were risk management interventions are physician practices, pediatric practices. I'm trying to think there was a third one. But those are the ones, in fact, that are primarily consulting-based disciplines and sort of lend themselves to some type of analytics. Oh, yes, the other one, I just remind me, psychiatry. Psychiatry was the other one where, in fact, it's more risk management. So this is what typically a risk management report would look like. It's called a quality report. It has a number of parameters that are measured, as I said, including in-hospital event costs, readmission rates, length of stay, the use of ICU, high care. All of those parameters are actually considered in this type of an investigation. And usually it goes through various stages. The provider is consulted with, there's counseling provided, and only when it comes to a point where they believe that the practice is actually being recalcitrant in some way, not offering information, not willing to change, will it then become a slightly more intense type of engagement, and I'm often called in at that stage only. So what I wanted to highlight, though, and this comes from a very separate type of investigation. It's got nothing to do with the risk management investigations that I was talking about. But this comes from what authority does the administrator or the managed care entity actually have to conduct investigations? And it really comes from a very specific investigation relating to pharmacists, where in fact the question was then put to this particular scheme, on what strength did they actually ask for the information that they were asking, and we wanted to know how they were mandated. Now, we know that schemes are creatures of statute, and when they actually engage the services of an administrator, of a managed care entity, there's a proper contract and a mandate that has to support that. When we were told that, no, this is part of the scheme rules, and then we said, point us specifically to which scheme rule, and they pointed us to this particular scheme rule, and lo and behold, that particular scheme rule specifically refers to member fraud. There's nothing in the scheme rules that refer to provider investigations. We then asked on what strength they actually were requesting the information. We were told there's a fraud policy. We asked for the fraud policy. It never materialized. I have grave concerns, and I think the question should be put to every single funder that you're going to be investigating, to ask on what authority any of these investigations are performed. And I want to emphasize one point. We know that we work in a third-party payer model in the private sector. The relationship is between the scheme and its member, and there's a separate relationship between the patient and the doctor. There may or may not be a direct relationship between the scheme and the provider. And
I mean, why do you say that Section 59 of the Act doesn't apply? Why do we have to go to the rules? Because my understanding is that all of this investigation and recovery are done under the Act.
The fact that they're actually doing the analysis on a practice has to come from some instruction. Section 59 itself doesn't say that you can actually do the type of analytics and investigation into a practice. That has to come from a mandate that a scheme would give an administrator or managed care entity or forensics department to say, you can take at a practice level, do the analysis. And I will talk about Section 59. I'll talk about Section 59 and Regulations 5 and 6 at the end of my presentation, if you don't mind. But this was of grave concern to me. And the other reason, issue that I wanted to raise, and I emphasize, the scheme rules are designed and written in a manner which brings about clarity in the relationship between the scheme and its membership, which creates a difficulty when the scheme actually then takes it upon itself to investigate and sanction providers, because the question is about whether they have the authority or the jurisdiction to do so. The other factor that I wanted to emphasize here is that it becomes easy to understand your rules, the scheme rules, if you're a member that belongs to a specific scheme. And we know that at any one point in time, a member can only belong to one scheme. But to expect a provider to be au fait with the rules of 82 schemes and various options is an impossible, or to be on the side, a very difficult task. And that, to revert to, because the question was put once, and I asked them, why would you impose this requirement on a provider? And they said, but our scheme rules say so. And I said, is the expectation then that every single doctor who practices has to know scheme rules of 82 different schemes in the country? It is not practical. And oftentimes a patient walks into a doctor's room unannounced, or they land up in casualty. For the doctor to have to apprise themselves of the scheme rules of every single scheme, I don't believe that was the intention of these rules. The intention of these rules was to govern the relationship between the member and the scheme.
I mean, I think we can accept that. I mean, I think the real issue is whether or not Section 59 empowers the scheme to claw back monies from doctors.
Yeah, I will talk about that. I have got my own interpretation of Section 59 and Regulation 5 and 6.
I
And
mean, all I'm saying is that I
yes.
think that the criticism that doctors shouldn't know each and every rule, I mean, that's fine, but for a different exercise, because the statutory source that's been put squarely before us is Section 59.
Okay. So in terms of systemic issues, I wanted to just explain this. This did come up, the whole issue is around discrimination. I have to state categorically that in our experience, we don't see any racial considerations applying in what initiates an investigation. However, I do think it's important for the panel to understand that there are some systemic factors that may result in why practices that operate in primarily low socioeconomic areas are the ones that are actually more susceptible to these forms of analytics. The one aspect is that we know that the scheme membership is primarily in LSM 7 to 10. Okay? There's a study from Econex that actually confirmed that. So that's your higher socioeconomic groups. But it's evolved over time where, in fact, members have actually become members of schemes through the employer agreements. And there was, in fact, a great effort made to try and bring in the low-income groups into the medical scheme industry. However, the scheme design did not evolve and change in accordance with that drive to bring in the more blue-collar workers. What is prevalent and remains in place are the levying of co-payments when patients actually go out of network, for example, when they use off-formulary medication. There's also deductibles. So if you electively choose to be admitted in a facility that is not part of the network that you belong to, you can actually be levied with a deductible. This concept of savings accounts as well, it's all part of the new generation schemes. And the scheme rules themselves actually create some of the problems that I think providers actually have to deal with. Things like exclusions for outpatient diagnostics. So if you have a patient that has recurrent headaches and you really want to do an MRI on this patient and they don't have disposable income or don't have a savings account, the chances are that the doctor would want to admit that patient to be able to perform some of those diagnostics, which probably in the longer term will create a slight distortion in that practice, because that practice will have a higher admission rate than a practice that doesn't have to admit, because they actually work or operate in a higher socioeconomic area where in fact patients are quite willing to dip into their pockets and pay for some of those diagnostic tests. So these are systemic problems. There's also non-payment for certain functions that providers are expected to perform, and they're expected to perform that either by the scheme themselves or by employers or by members. So for example, doctors have to write reports, especially psychiatrists have to write reports when patients need to either be given absence from work for a long duration of time. All of those reports that take a fair amount of time to compile are not funded by medical schemes. And it's probably unrealistic to expect a patient themselves to pay for those reports. So what happens is that the doctor may well, and I'm not saying it has happened, consider claiming for consultation in lieu of having to write a report. Again, creates a distortion in that particular practice. Similarly, when a doctor has to apply for PMB, which is really part of what the scheme demands, okay, that application for PMB benefit is not covered by the scheme out of the risk benefit. It's paid for, if at all, from the MSA. And in MSA, often patients really try and protect their MSA where they have that. So those activities that a doctor is expected to comply with are not being covered in the normal scheme of what a scheme should pay. And so some of the providers circumnavigate these restrictions by either charging for a consultation in lieu of either a teleconsultation or a report that they have to write. In terms of procedural issues that we've had with the investigations, and I speak primarily in this instance about the forensics investigations, there is definitely an asymmetry of power and resources. Providers are summoned into fairly big organizations in the big cities to come in and present their cases. They're given very short notice. There's a conflation in terms of whether this is a fraud investigation, abuse, or waste. It's not clear from the letter that providers are given exactly what the investigation is about. They're given unreasonable timelines. They've asked to bring in significant patient records within a very short period of time. And often the time frames that they're given or the number of patients they expect, files they're expected to bring in is inconsistent. It's not the same for different providers, even within the same discipline. In terms of the conducted hearings, it's very inquisitorial, often led by the investigators themselves. It's been described as a mediation. It is anything but a mediation. In legal terms, we know what mediation entails. You'd have an independent person who would preside over mediation. That doesn't exist. There's a dearth of information that's provided, in fact, at the outset. It's very intimidating, so it's not unusual to find at the entrance to a forensics department a sign that says, "Smile, you're on camera," so that you know that you're actually being scrutinized and every single word you say is going to be recorded. You're asked to sign record of proceedings at the very end of your engagement. You're not allowed the time to peruse the document properly. You're not allowed to take the document home and return it the next day or when you're comfortable with the content. You're expected to do it then and there. Oh yes, and that's an important point that my colleague just reminded me of, is that if you actually dispute any of what they've recorded in the record of proceedings, you're not allowed to make an amendment. They won't allow you to do so. If you asked about the tip-off, again, you lured into the meeting because they asked you to bring in these records, and then when you arrive at the meeting, they tell you about this tip-off, and you ask about the tip-off, you're not given information about who complained, what the nature of the complaint was, the date, time, or any of the aspects about the complaint. When asked whether that information will be forthcoming, you're told that in fact it's subject to whether the patient or whoever the informer was will consent to you being given that information. And then in terms of consent, so a lot of our providers raise the issue of patient consent. I know it's come up several times in submissions that you've heard, where providers are concerned about divulging clinical information to third parties. When we've advised most of our providers not to make this an issue because we realize it goes nowhere. If you resist and you say, "I'm not prepared to provide you with the clinical information," basically they will just suspend your practice. So we encourage them to, in fact, provide the information, but we prefer that the information be presented in person so that, in fact, when you're going through the files, you're not handing copies of clinical notes. You're actually explaining what those notes actually mean. However, and it really comes to my next category, which is the substantive issues around this consent. So some of our providers are still quite skittish about having to provide this information. So we've asked the funders if they are comfortable that they have a right to access this clinical information, would they be prepared to indemnify the provider in the event of litigation where in fact the patient or a family member says you disclosed what was confidential and I'm now suing you for having breached confidentiality. Would you be prepared to indemnify these providers? They're never prepared to indemnify the providers. So if they're as confident as they are that they have every right to access that information, why will they not indemnify the provider? And we have got written proof. It's in the pack that you will receive of letters of responses that we've received from various funders saying that they will not indemnify providers. So in terms of the substantive unfairness, the letter that actually invites the doctor in for consultation is vague, lacks details. All you potentially ask for is to bring in a set number of files. And what's interesting, and I think I do mention that specifically, but before I lose that, you're asked to bring in, say, 10 or 15 files. But what you're presented with is, in fact, 3 years of history about your practice. So you're completely taken aback and you're unprepared for the type of questions that are raised in that investigation.
Before you go into this, the first letter just says we're inviting you for inquiry into your practice. We then email them to ask what exactly is it that you wanted in, and then it follows with the patient first.
Okay. Can I ask my colleague to just explain what she just did? Because I'm going to be a parrot otherwise, or not.
Indeed.
Okay.
Thank you very much. Nabila Mulla from Inmula Incorporated. Just in terms of the letter where it states that it's vague and it lacks detail. From experience, the initial letter received simply states, we would like to invite you to a meeting for an inquiry into your practice. Please provide us with a date and time on your availability, and that's essentially where it starts and ends. Often, I have to then email the relevant schemes and say to them, we acknowledge receipt, place yourselves on record, and please advise the nature of the investigation and what information is specifically required, which is when we receive the patient information or the files that they require for purposes of the investigation. In addition to that, it's also when they ask for the provider's diaries, clinical records, etc., and that's essentially where the dispute then starts.
Just tell me about these tip-offs. I mean, what is the complaint? The scheme saying you are not entitled to a tip-off. It's anonymous for a reason. So, but you seem to believe that actually there is no tip-off at all. I mean, I don't follow. So you could have one or two alternative ways of looking at it. The one is that the scheme is entitled to withhold the identity of the anonymous whistleblower because that's the law in this country. The other is that there is no whistleblower, and that's why you are not being told. So I don't see what the complaint here is. So
I think you're correct. It could be one of those two scenarios. I think, however, the provider would need to know a little bit more information about what is the nature of the complaint or the tip-off. So was it about him not, in fact, providing care? Is it about the type of care that he rendered? Whatever the complaint might be, I think he needs to be afforded the opportunity to at least understand what the nature of the complaint is. No information is forthcoming about what the complaint is.
But I mean, disclosing that might inadvertently disclose the identity. So if one takes seriously the obligation on schemes to keep whistleblowing information confidential, it's unclear why you say that these are phantom complaints. Is there any other information other than the refusal by the scheme to disclose whether it's the nature of the complaint or the identity of the complainant? What is the reason why you say that these are so-called whistleblowers?
Well, I think it is primarily for the reason that, in fact, no information is provided, and you're right, maybe that is in terms of protecting the complainant. However, in one particular instance, after information was provided about the practice, in fact, it turned out that there was what was purported to be the issue that was raised in the complaint or the tip-off actually never materialized. It was a non-issue. The provider was able to substantiate every single claim that he actually presented, so which led us to believe that maybe this was just a ruse.
I mean, I suppose even there's still a comeback from the schemes, which is, if a whistleblower, let us assume there is a whistleblower, complains about X, they may be entitled to also investigate Y, because usually an indication of malpractice in one area might be indicative of a larger. I mean, I suppose you could say, well, what I want is not the identity of the whistleblower, and I don't want the nature of the complaint. What I want is to be sure that there is, in fact, a complaint. And if you can satisfy me that there is, in fact, a complaint and that you did not initiate this on your own, then I will cooperate. And that the flaw in the system is the complete refusal to disclose even the existence of a complaint, and that they expect you to accept their word that there is a complaint.
Agreed.
I'm concerned about this because we have been provided with copies of whistleblowing reports. So I'm concerned about what the nature of your allegation is.
Well, my concern is really that, in fact, no information is provided, not even a date and a time when a call was made, or whether it was actually a call. No information about what the so-called tip-off is.
So are you arguing that in order to be fair to the provider, a certain amount of information has to be provided in relation to the tip-off, and that would be the date of the call?
The manner in which the complaint actually was brought to the attention of the fund, the date and the time, something to that effect. Or even if there, some vagueness or some indication of what the nature of the complaint is. So information about how the provider is classified as an outlier, as I emphasize, this relates specifically to the forensics. I think I don't really have an issue with the manner in which an outlier is classified when it comes to a risk management intervention. But when it comes to a forensics investigation, when we ask, why do you classify this practice as an outlier? Often there was a very crude analysis done at a coding level. Well, this particular provider is the highest utilizer of this specific code in the entire country, is what we're told, without any further adjustment for how busy is this practice. What is the nature of the patients that frequent this practice? So that level of detail often is not provided, or it's not taken into account from what we understand in this particular analysis. So, for example, with a psychiatrist who happened to have fairly long consultations, according to the forensics investigators, I put to them, I said, can you please show us what this doctor's admission rate is as opposed to his peers? Because in fact, perhaps a slightly longer consultation can avoid the need for an admission. Can you tell us what the readmission rate is? Can you tell us what his...
Can I ask you something you mentioned earlier? When you say you have not identified instances of racial profiling, but you've identified instances of a systematic or systemic impact, I don't follow what the distinction is. I mean, you've done this work for a while and you've shown us your figures. I mean, out of the figures you have shown, what is the amount of people that are being investigated? Are they black or white, and what are the statistics there?
So you did see what the statistics are in terms of black and white. And why I say it could be systemic as opposed to, that is not the starting point of the investigation. It's not as if a funder is saying, let's look at all our black practices and let's try and understand what's going on in the black or
your stats are 87% black and
yes.
13% white.
Just
now that's just I mean, if you deny that is racially loaded, I mean, there has to be another explanation why your figures show 87% black and 13% white.
So I can't talk for that particular type of imbalance in my numbers. I also wanted to say that we are referring professions, so there could be a referral bias in my figures, that in fact black doctors talk to other black doctors to say, try and use Nabila and Hassim to try and assist you in your investigations. So it could well be that the clients that we're dealing with, through word of mouth referral, that's why the stats are skewed like that. However, I am more inclined to believe that there are more underlying systemic issues, and that they're around the things of trying to avoid having to ask a patient to pay a co-payment, having to avoid. I want to emphasize one other aspect, and that is, as much as we have cross-subsidization within schemes, there is cross-subsidization within practices as well. And in fact, practices that operate in low socioeconomic areas, where they in fact either provide pro bono services or at a lower cost for cash patients, are probably utilizing the medical scheme funded base of their practice to subsidize the balance of their practice, and which can skew claiming patterns.
So the difficulty with what you're saying, as far as I understand it, I can understand it as a description of a social reality, but you are referring to it as circumvention, and the schemes that the administrators would refer to it as fraud or abuse. And I think the law might
be on the side of the
schemes and the administrators.
Can I just emphasize as well that none of the clients that I dealt with that actually emerged as a problem. Almost all of our problems were billing irregularities.
But then if you haven't got any personal experience of it, then we have to treat it with some circumspection.
Correct.
Can I just ask, what is the total number of clients you've had which got you to this figure of 87%?
15. There were 15
So it's
for that
15.
period of time.
Okay.
There have been several others since.
Okay, and that's obviously a very small proportion of the total.
It is small.
Okay.
It is small. So, as I mentioned previously, and I think we spoke about it quite extensively, there were no risk adjustments or outcome measurements in the forensics analysis that were performed. Providers are asked to come in with a small sample of files, but then the investigation includes all patients from all schemes administered by the administrator spanning 3 years. And the type of information requested often exceeds what in fact the scheme's mandate is. Now, I can fully understand that the scheme has a right to ask for the clinical information pertaining to a particular claim. However, I have my doubts about whether the scheme is entitled to ask for invoices, for purchase invoices, for example, of a pharmacy. I have my doubts about whether the scheme is entitled.
They're entitled to the clinical information. I mean, this is one of the big disputed areas in this inquiry. The doctors have told us that there is no way the schemes are entitled to clinical information. In fact, they are under an obligation under the National Health Act, I think Section 15 of the Act, specifically not to disclose clinical information absent the consent of a patient.
So if the information that explains the claim is clinical information, then I think the scheme is entitled to understand that. So on what basis did you diagnose this patient as having, or you're claiming for admission for bipolar, is that in fact the diagnosis? For example, that would be the kind of information that the doctor would have to provide to confirm that in fact the code that he used was an appropriate code in billing.
And how would the doctor provide that information?
So the way our doctors do is they actually go in with their files. We try and avoid them having to send reams of paper through. They will step into the consultation with their files and explain based on the patient number and the information that in fact or the diagnosis that they made, or the claims on specific days, and what they did for that particular patient at every engagement or consultation.
I've begun to wonder why the patient can't be engaged to confirm a diagnosis. Have you got any comments on that?
No, I don't really have a comment on that, except to say that I think a patient can comment on the diagnosis, but probably not on the various billing codes. I don't think they have that level of understanding to be able to say for each of the
I'm limiting my question
procedures.
to the need to see the clinical notes for diagnosis purposes.
Can I just explain one more thing? The reason why, and in fact in the consulting practice, the reason why the schemes explain why they need the clinical notes, and it's a very crude manner in which they utilize it. In a consulting practice, which is a time-based practice, the volume of the notes gives them some assurance of the duration of the consultation, which in fact, one can't tie the one with the other. Because if you're seeing a patient repeatedly, you may well have to do a fair amount of counseling if it's a consulting practice and if you're doing something like a psychiatric consultation. You may only have to put down 1 or 2 words to confirm exactly what was done because the diagnosis is already made. You don't have to put reams and reams of notes.
Can I just take you to this because I do want to get your evidence. So you can take a practical view that, listen, if you don't provide clinical notes, you're going to be cut off. So, do the right thing, just give them. Or you can take the view that is the correct, legally correct thing to do is to disclose the Now, what is your actual evidence? Are you saying you've decided on the pragmatic route that in order to save your practice from an arbitrary termination, disclose the notes? Because it's quite clear that doctors who have come to give evidence before us and the medical associations are refusing to disclose these notes on the basis that they are under an obligation ethically as well as legally. But you are saying you've advised your own clients to just disclose, to dispense with it.
Yes,
But
I have. And it's for that
the basis
reason.
for that advice could be pragmatic and nothing more.
Absolutely, and it is that. So if you want, our advice to them has been if you want to stand off, you can expect for your practice to be suspended. If you can withstand that, fine, we are creatures of instructions, we'll take that route. However, our advice to you is to rather provide them with a clinical note, especially if you know that in fact you can justify all your claims, and allow this matter to be resolved expeditiously. We also use that approach, by the way, when it comes to having to accept some of the calculations in the clawbacks. Even though they may not be correct, either because of the interpretation of a billing code, for the simple reason of resolution, we would advise them sometimes to accept a lower amount or negotiate a settlement with
Could you just tell me on the clinical notes, has Discovery ever asked or told you that you can redact certain information, or do they want the full scope of the clinical notes?
If I may just come in, they actually don't permit it. They want the documentation in original form, and it gets compared in the investigation the electronics versus the hard copies to make sure that nothing has been redacted or changed. And they even go so far as to inquire why things are written in pencil and not in pen.
Thank you.
So I do want to talk about the information that they ask for, because what they do ask for, which I think is quite invasive as well, is things like doctors' diaries, which in fact I don't believe any particular scheme has a right to access. It is an issue of privacy, and we've actually withheld that level of information. We've also advised our clients not to provide information like invoices, purchase invoices, and as you said, oftentimes we are saying to them, provide information that will allow us to dispense with this whole investigation.
So if I may just go back to the disclosure of clinical records. We've had an instance where members were contacted to notify them that we need to disclose your clinical records to a medical scheme for purposes of investigation, and where we've received affidavits from members stating that they do not wish for these disclosures to occur. These affidavits have been submitted to schemes informing them that the members have directly not consented to the disclosure. And irrespective of that, they still have demanded that these records be disclosed. So it's also important to understand that when a member is under investigation, that scheme that is investigating them holds 90% of their income. So it's a matter of whether they're able to live without the 90% versus disclosing it and going through the process.
And then being provider, yeah. In terms of the blanket consent, we've been told repeatedly, and that was the other point that you made, was, you know, we've advised our clients to try and just provide the minimal amount of information to allow them to continue with the investigation. But the explanation that we've been given by schemes when we ask why they have a right, on what basis they have a right to ask for the information, has been this blanket consent. Now, this blanket consent comes with when you actually sign up to be a member of a medical scheme. Things change. When you joined, you could have been a 21-year-old young, healthy person. 10 years later, you may well have contracted HIV. That information, that blanket consent, I'm not convinced actually would cover instances where, in fact, information of sensitive nature is demanded.
I think we read that clause at the commencement. My understanding was that it's a contract between a member and a scheme. It's not binding in any event on the doctors.
And then the other bit that actually...
And presumably consent means informed consent.
Informed consent at that point in time. There's also this, and again, for pragmatic reasons, we sometimes do say, let's just, work with them to cooperate, and this matter can actually go away. Because what they threaten, and it is a threat, is that they will disclose the outcome of their investigation with other schemes and funders. And they've done it on several occasions. My concern is whether they have the authority to do so, whether they then become the tip-off or the informer to another medical scheme, and we see a pattern within weeks of an investigation, another medical scheme or administrator will undertake the exact same investigation and call the provider in for a very similar reason.
May I just pause you there and take you back to your theme of what information is often demanded from providers? And you've made the point in your written submission at page 28, paragraph 86, but you were touching on it and didn't complete the submission, I don't think. But it was about when pharmacists are required to produce their purchase invoices for stock. And in your submission, you say that if a pharmacist is unable to produce an invoice, it doesn't automatically mean that a legitimate service was not rendered. Can you explain why?
Okay. So, you know that I'm a pharmacist, and I've worked in retail as well as in hospital pharmacies. Oftentimes, you have a patient with you for an item that you actually didn't purchase. You borrow. You'd borrow that from another pharmacy. You do a bit of an exchange. You'd allow another pharmacy to actually provide you with stock in exchange for other stock. In some instances, a pharmacy will purchase for several pharmacies. One pharmacy will purchase, and so there's a lot of that type of exchange going on. It's also just a proxy, because one particular medical scheme will only deal with specific claims, and your purchase invoices may be completely unrelated to that particular claim that you submitted to them. Worst case scenario, if a provider of healthcare services is obtaining their products from an undesirable source, it it doesn't mean that the service wasn't actually provided. And that's a totally different type of investigation. That becomes theft or fraud or whatever that might be. But the simple fact that you don't have an invoice doesn't necessarily mean you didn't provide the service. But more often than not, what happens is that you don't have the item in stock, you borrow it from another pharmacy. You won't, you basically just have a trade-off, you exchange for other similar value products. And you don't necessarily have to buy, especially low-moving items, you won't keep everything in stock.
And is that borrowing lawful?
Yes, yes it is. On that point of pharmacists' claims, by the way, the other point that funders repeatedly raise is that there wasn't a consultation that precedes the issue of medicine. Well, there doesn't have to be. Because firstly, in many cases, you can get telephonic scripts without any consultation. If you're like me, I have family members that write up scripts for me, and I don't actually have to consult them, and they won't charge me. And in the one particular instance, in one investigation, there was the practice that actually generated the scripts for the pharmacy was already put on direct payment. So in fact, there were no reimbursements going through to that practice that's generating the scripts of the doctor's consultations. So he had a cash practice, and in fact, he still generated scripts, which the pharmacist could actually fill. So it doesn't mean that there's no consultation with the doctor that precedes the issuing of a script, that in fact there's something untoward around that. Okay, so just in terms of the substantive unfairness that continues. So you're asked to bring in a specific number of files. They may raise an issue with the manner in which you code and you bill, etc., on that sample size. But then they extrapolate all of that information to your entire practice for 3 years. And that's what the clawback constitutes. And in terms of considerations of Section 59 and Regulation 6, I'll explain to you why I don't believe that that is actually allowed in terms of the Act and the regulations. There's also the coercion in signing the AOD. We have had instances where, in fact, providers come to us after having signed the AOD, and we say to them, unfortunately, you're now dealing with what, in fact, the Council for Medical Schemes have ruled, which is the law of contract now, and for you to be able to unwind that particular signing of the AOD is going to become hugely difficult. So in many cases, in fact, that just, goes nowhere. In terms of the automatic suspension, that can happen literally in the consultation, even if you're deferring certain aspects of the consultation. So we've got a specific case which is still pending, where the issue arose around whether the provider was entitled to employ technicians to assist in the provision of services. This whole matter revolves around students and technicians as opposed to qualified technologists, and the provider was reported to the HPCSA. Notwithstanding that the HPCSA cleared the provider, did not find that there was anything untoward or unacceptable about the practice, that practice has remained suspended. So without any further ado, they suspend the practice then and there and say, doesn't matter what the outcome of the investigation is, we will not reinstate this practice for direct payment.
This particular practice was also reported to the SAPS, and obviously nothing became of that.
And then when we asked about interpretation of billing codes...
Sorry, why do you say obviously nothing became of that?
It wasn't a fraud-related incident, so I don't understand under what referral they would have made it to the South African police in any event, because there was no issue or element of criminality.
I don't think we've come across a single instance that was successfully prosecuted, even though it was designated as fraud. But maybe you have.
Neither have we. In terms of, I want to come to the subconscious bias in a bit. I want to continue with the issue of experts. As I mentioned, most of our investigations, or where we were assisting, revolve around the interpretation of codes and the use or the alleged misuse of codes. When we ask on what basis the funder believes that their interpretation is correct, we're often told it's because of an expert that advised them. When we ask who that expert is, that information again is not forthcoming. Now, in one particular instance,
What information is this that they...
who's your expert?
No, I'm talking about the nature of the information provided by the expert.
It's in terms of the interpretation of codes. So can this code be used for this particular type of intervention? I think you've received a fair amount of input in terms of the billing codes and the issues. I'm not going to go into a lot of that. I think I have one slide that will touch a little bit on it. But this interpretation of code is a huge problem, especially where medical science has actually evolved, and in fact the billing codes have not. So there's a need to try and use similar codes for the type of services that are being rendered. In one particular instance where a provider happened to pick up on an email trail and was able to identify who the so-called expert was that was advising the medical scheme, it turned out that that particular expert didn't even belong to that subspeciality of that practice. So they're relying on information from experts that in fact would probably not even qualify as experts. I also want to emphasize one other aspect which I think is of huge concern. These so-called experts that funders rely on are oftentimes the heads of societies. Societies are voluntary associations. They're not representative of all providers out there. So when you take the societal view as being authoritative in the interpretation of codes, it may not be inclusive of all practices out there. Having said that, and you've had submissions from one of the societies as well, I specifically have some concerns around the use of some of the societies, especially when those societies are aligned to organizations that are in fact service providers to medical schemes. My concern is how objective is that information that you're receiving. And those very associations and representative organizations are involved in some of these forensics investigations. They're conflicted. Their client is the scheme. How can you be advising a scheme, or how can you be representing a provider in their dispute with the scheme when in fact your significant portion of your income comes from that very scheme or administrator? And so I have grave concerns around it. In terms of the subconscious biases, I want to mention that for one of the very large forensics departments, up until recently, it was primarily only white. There were no investigators that were of any other color that were engaging with providers. Only recently did we find that there was one Indian person who was brought into some of these consultations with our providers. There's a subconscious bias that comes with that. So when we put to the scheme that in the instance where there's a significant co-payment or there's a claim that is not part of the benefit design of a scheme, what do you expect a provider to do in that instance? The kind of very flippant answer that we get is, well, the patient should just pay with their credit card. That shows complete ignorance of the type of practices that some of these doctors actually operate and the areas in which they operate. Many of the patients who our doctor who frequent some of the practices practices that we've actually represented don't have disposable income. They really, really don't have access to the kind of monies that will just pay out of pocket for very high cost interventions. And that's where I say the subconscious bias comes in. The issues with coding, I'll go through this quite quickly because I think you've received a lot of input on that. But there are time-based and procedure-based codes. And we've put in an example in our pack for you as well of a specific coding where, in fact, in some instances, the codes are quite explicit. They say you cannot use this code when that other code is used. So it's quite explicit in the definition of the code when you can and can't use it. That logic is then applied by the medical schemes for other codes. And when we actually inquire on what basis they arrive at that interpretation, they can't provide us with that insight. So even on a literal interpretation of the code, it becomes very difficult to understand exactly what their rationale is for why they exclude certain combination of codes from being used. There's a lack of ownership of the codes. I think you've heard enough of that. There's no consultation between providers and funders on how to properly interpret these codes. Again, we urged funders to try and assist providers, especially providers that are new new practices to assist them in how to interpret the codes, and we were told that's not their job. And also, providers who don't belong to societies where they can get that information through the guidance of societies are hugely disadvantaged. They don't have the benefit of that type of guidance. They don't have the type of mentorship that comes with being a member of a society. But they shouldn't be discriminated against. And in fact, there should be a fair amount of transparency and engagement between providers and funders in terms of the proper interpretation of codes. What is quite important, and I want to emphasize, that in consulting practice, and they're very much like us, we sell time. They sell time. When we did an analysis for a specific practice in terms of his income per hour, this is a specialist with many years of experience. His income per hour is less than a junior attorney. That these codes and the kind of units and costs that are allocated to these codes are completely out of line with the level of expertise of providers out there. And I think some cognizance needs to be had to that issue.
I don't know whether the legal professional fees are a good comparator, but I hear your point.
Probably not.
I mean, I suppose because, you know, you could charge anything you want if your patients are willing to make co-payments. I mean, that's the counter that one gets when you complain too much about the low tariffs.
I think in many instances, I think that, you know, providers don't have that luxury. They have to work with and in fact, in some instances, I think we've heard, and what Nabila was alluding to, when your practice is so reliant on a specific scheme or administrator group, you can't risk not being paid by them. But not only that, I mean, in many instances in the low socioeconomic areas, practices are reliant on direct payment, not only on the income that they get from the schemes, but from direct payment from the schemes, because they really can't afford to have to claim immediately from patients or have to chase up on payments when in fact members have been paid directly by their schemes. The complexity of the procedure sometimes is the disconnect between the coding, and I'm really not going to go into it. It's got nothing to do with an investigation like this, but I just want to share one example with you. One of our providers happened to be a contracted provider for a low-income plan. And so he's often called in because that low-income plan only pays for PMB, and these PMBs are often only emergencies. He's then called in at any time of the day or night to deal with an emergency procedure. He explained to us that in one instance he spent 6 hours in theatre and he got paid about 3,000 rands, somewhere in that region, for that entire. It was linked to a motor vehicle accident because there were no codes that in fact that particular scheme would actually cover, or they refused to cover all of the other codes and the modifiers that he would have used in that instance for any other patient. In terms of the modifiers, I think it's quite important that I also explain one aspect of interpretation of codes. For this particular provider happened to be an orthopedic surgeon. There's a code which says you can use a specific code for when you actually, when a joint is involved in the care, well, when a joint is violated. When the doctor had to perform the procedure, he had to violate the joint as part of his treatment, and they refused to pay for it. They were only prepared to pay for that particular code when in fact the cause of the injury was a violation of that joint. They did not take into account the fact that in fact having to treat the injury meant he had to violate the joint, and they wouldn't pay him that particular code. So I just, I think it's very important that there should be proper engagement between providers and funders to come to some resolution around these issues. Examples of misalignment of codes between funders and providers, particularly in cardiology. And the example I want to cite here is where clinical technologists are involved with cardiologists in, for example, the insertion of stents. The kind of coding that cardiologists are allowed is totally misaligned with the coding that the clinical technologists are allowed for the very same procedure for the very same patient. So they will restrict a cardiologist only to at a vessel level, but it doesn't matter how many stents you put in, but they would restrict a clinic to the use of that code once only for the entire procedure. So there's a misalignment. And again here, in terms of resolving this issue, the responses from funders are different. So one particular major funder was quite happy to try and create some sort of conformity between different disciplines involved with the same type of care, and the other one was said, no ways, we're not prepared to entertain that.
Isn't that, aren't you describing something that's not really within our remit? I mean, how the funders and how the funders, the schemes and providers resolve that problem is not something we need to consider. What is it? The issue for us is where codes are used and the scheme says you used these codes incorrectly, resulting in either in an overbilling. So in those circumstances, why is it not why would it not be that an explanation from just, let's say, the doctor, why would that not be sufficient to explain how the codes were used and the problem goes away?
So I want to bring that because it does have a direct bearing on this investigation. Because the reason why a specific clinic uses those codes is because, in fact, the doctor is allowed to use the codes in the same quantum or in the same quantity for a specific event, and he's not, and he's actually called in as an outlier because of the number of times he uses a specific code. So it has a direct bearing on this investigation.
But once you explain that
No.
this is why why would that not then resolve the problem? Because you're not an outlier.
They find it unacceptable. They're saying that the cardiologists are entitled to charges in multiples, but the clinic isn't. They've not been able to resolve that issue. The inconsistency in the manner in which these investigations are also resolved, I want to highlight that because you just reminded me of something else. When you say the doctor explains, in some instances, the doctors are more than willing to come in and accompany their clinical technologists as part of the investigation. In other instances, they're not. And when we ask why, in fact, they say, we don't want to actually have the spotlight turned on us. I'm not prepared to go in there to back my clinic because, in fact, then they'll start investigating me. And we've had instances where, in fact, the outcome of exactly the same, and this I will emphasize is hearsay, this is not my direct experience, where the outcome for the same professional who went in with their referring doctor was different, and the issue was resolved differently to when a clinic went in on their own without the attending doctor. For exactly the same complaint, which also talks about inconsistency in terms of the sanctions. That just so happens in that instance, by the way, that the clinic that actually had the issue resolved speedily and amicably without having to have any clawback happened to be white in that instance, and our client, whose doctor was not prepared to come in with him and support him, happened to be a black professional. Just to put that out there. Is there anything else?
Just the fact that because she's saying that if they've given an explanation, why does that not suffice? It's the unilateral decision in terms of how a code interpreted, because that code doesn't say you can only put in first and professor.
So what Nabila's explaining is that in fact it boils down again to the interpretation. When the funder is not prepared to accept even the logic and the explanation from a provider, it really doesn't help to actually have them in to support you. So, Mr. Chair, this is the part that you were actually asking me about. This is, I think you're quite familiar with Section 59 and Regulations 5 and 6. But I've emphasized in terms of Section 3A. So this is what, when we've asked on what basis they're actually allowed to sanction, claw back, or investigate, they often fall back on, this is the funders, fall back on 59.3a, which is any amount which has been paid bona fide in accordance with the provisions of the Act to which a member or supplier of healthcare is not entitled. That definition of not entitled has not been fleshed out. This, by the way, originates from, in fact, normal insurance policies, where, in fact, they're not entitled to claim for what's not covered, for assets that are not covered by the policy, and for individuals that are not covered by policies. But this issue of not entitled in terms of the Medical Schemes Act has not been fleshed out, explained, or elaborated on. Then B, which is where the clawbacks can actually be invoked, applies specifically in instances of theft, fraud,
And
negligence.
in the insurance
and
industry,
misconduct.
how do they deal with fraudulent claims?
So in the insurance industry, remember, there's the purchaser and the payer are different people. in healthcare, where you have a third-party payer. So they will claim back directly from the person who was the policyholder, and oftentimes they'll cancel that policy. Whereas in this instance, they're claiming back from a third party that they actually remunerated or reimbursed. It's a very different dynamic.
But I mean, the supplier stands in the shoes here of the beneficiary of the service. Now, I'm trying to test why you draw a distinction between not entitled and fraudulent,
So
because
I'm-
it seems to
I'm-
me that it can be interpreted widely.
It may well be. I just wanted to emphasize that it has not been clarified in terms of on what basis you're allowed to actually claw back where you believe it's not entitled. So I want to go back to this issue around interpretation of codes. If I have a specific interpretation of a code and I use that code in a manner which I am convinced is appropriate, and you differ from me, does that mean I'm not entitled? And that really
Isn't
is where
this
the
exactly the
disputes-
reason why we're sitting here? Because there's a
Yes.
fundamental difference between what the schemes and the administrators think and what the providers think.
Correct. And I don't actually have a clear answer. I'm just sharing with you where I'm not sure that this issue of not entitled can be applied in such a rigid way, when in fact there's a clear misunderstanding or disagreement in terms of interpretation. It's not as if there's
I mean, I can
explicit fraud.
accept that if there is no fraud, then you were entitled to claim. If there is no fraud and no excessive billing, then you are entitled to claim and entitled to be paid. But if there is fraud, then the fact that in the insurance context, entitled means covered within the frame of the contract is not decisive, because you are still not entitled if you are fraudulently claiming. The question is, what is the method of recovering that which was paid outside of the terms of the agreement? So the one view is that the schemes themselves become the judge, jury, and executioner. The other view is that perhaps there should be a third party making those decisions. And there's a pushback around the idea of a third party, because the risk is bigger to the entire pool of the membership, and there has to be an effective way that expedites the clawing back.
I make some recommendation, which I think it's in my final slide of how I believe this could be resolved. But I think in terms of regulation, and this,
So I thought you also wanted to talk about sub B. You only spoke about sub
oh yes.
A.
So what I want to say about B is that in the instances, and I think I agree with you, that where it's clear fraud, negligence, and misconduct, they would be entitled to clawback. Where it's simply because of an interpretive issue, I'm not sure that it actually qualifies under B for that it needs to be deemed to be a loss, as B explains.
Well, I mean, there's another thing that arises in this inquiry. It's precisely what does theft, fraud, negligence, misconduct actually mean, and whether there should be someone else objectively establishing those as jurisdictional requirements before the power to claw back. The complaint is the power is overly concentrated in the schemes. So they decide what constitutes theft, and they decide what constitutes fraud. And often those decisions are themselves loaded with all sorts of objectives which are intended at recovering as much as they can. And they ignore the objective reality that actually there is an innocent explanation to most of these claims.
Agreed. I think the issue of fraud, I think for me, is far more, it's clearer. If you look at the elements of fraud, even in law, I think if those elements are met in the manner in which a claim is submitted to a scheme, I think it's pretty simple to say that that is fraud. But I think for the others,
But the question is, who decides that it is fraud? I think that's really the issue. The scheme will say, from our point of view, it's fraud, and the doctor will say it's not fraud.
Independent adjudicator. Agreed. I wanted to spend a little bit of time in terms of Regulation 5 and 6, because I think it's quite important. This is my interpretation. There's a very specific reason why Regulation 6.2 refers to a time period within which a dispute has to be raised. And it's for the exact reason of the difficulties that we've experienced in some of these inquiries or investigations by medical schemes. The idea is that within 30 days, if you pick up something that is of concern from a claim that's been presented to you, that you need to actually raise that dispute within 30 days. The 30 days is quite important. Everything is still fresh. Information is readily accessible. When you try and apply clawbacks that span 3 years, it becomes very difficult to be able to substantiate the claims, which is why 6.2 gives the 30-day time period. But then 6.4 says that if that isn't done, the onus shifts. The onus of she will shift to the scheme, who must bear the onus of proving that such an account, statement, or claim is in fact erroneous. That is not what we're seeing in these investigations. The onus still sits with the provider to be able to prove that in fact his claim is legitimate.
Advocate Hassim, are you arguing that Regulation 6 implements Section 59?
Yes.
And what do you make of the different wording then, when Section 59, as you've referred us to, refers to not entitled, theft, fraud, negligence, or misconduct, and Regulation 6 refers to erroneous or unacceptable, which seem to be different concepts?
So, Ms. Williams, I haven't actually looked at that in detail, so I'd prefer not to, but I'm quite happy to apply my mind and then revert if necessary. I wanted to just make these following points, and I'm almost at an end. So Regulation 6 recognizes and caters for the huge administrative burden of claims and payment administration. And importantly, it imposes statutory timeframes within which steps must be taken, specifically 6.2, 3, and 4. Regulation 6.2 requires medical schemes to raise any challenge to an account, statement, or claim within 30 days and to state the reasons. If a medical scheme fails to act within the aforesaid 30-day period, then in terms of Regulation 6.4, the onus shifts to the medical scheme. The Act, through stipulations in Section 59 and Regulations 5 and 6, make it patently clear that a claim for a service by a member or a healthcare service provider must be honored when the member is a valid beneficiary of the scheme, when the service falls within what's defined in that scheme, and when the claim has been submitted in accordance with the prescripts of the Act. Now, I want to raise a very important point here. The ability for a medical scheme to sanction a practice and to withhold payment is in direct violation of this, because in fact, in that instance, neither the patient nor the provider get reimbursed for a service that may well be legitimately rendered. And in fact, the question is whether in fact the scheme isn't being enriched through that process. Funders have adopted a blanket approach and have failed to meet obligations created in terms of Regulation 6.2, which said that a dispute must be declared and that in order to not fulfill its obligation that arise in terms of the Medical Schemes Act, in respect of honouring a claim, that it must prove that each and every claim that forms part of the dispute is either erroneous or unacceptable. And Ms. Williams, just in answer to your question, that specific section talks about a claim, specific to a single claim. It has to that dispute has to be declared for every single claim. You can't go back for 3 years and submit one clawback as a claim. It has to be done at a claim level.
Well, I mean, disputed where? Because the section says in the event of a dispute, but there is no dispute. There is a scheme and a doctor. The scheme decides what it wants to do, and the doctor might say, I disagree, but there's no way to declare a dispute. You know, the scheme just does what it wants to do.
Agreed. So where a medical scheme opts to claw back, it must do so within the prescripts of the Act and the regulations, and only in terms of claims where a medical scheme has paid bona fide, but which payment it has subsequently determined the member or the service provider was not entitled to. And that comes again in terms of the interpretation of what the entitlement is. And so it is my interpretation that in the instance of 59.3b, the test is that a medical scheme must have suffered loss as a result of theft, fraud, negligence, and any misconduct. And you rightly said that, in fact, you know, in terms of whose interpretation of whether that has occurred. So in terms of the so-called billing irregularities, it is my submission that, in fact, the schemes have failed to make a case for any of the above. In terms of conclusions and recommendation, Nabila wants to make a point.
Talk about where the money gets paid once it's been brought back.
Oh, yes. Thanks for reminding me. I do think that it's important for this panel to look into these clawbacks in a little bit more detail. I think it's quite important to follow the money trail. So not only did I raise the issue about the authority, about whether they have the mandate, but I think when the clawback has occurred. Now, in our experience, we know that, in fact, the clawbacks are done at a scheme level, but it goes beyond that. In many instances, these clawbacks are for claims that potentially were paid out of member savings accounts. And the question arises then, when you do a clawback, do you reimburse the member savings account? What happens if the members left the scheme? We know there's a huge amount of churn in this industry. What happens when the member has demised? Does that go into the estate of that particular member? because the claim originally could well have been paid from a member savings account. And so when the clawback is made and it goes simply into the scheme pool, that is probably incorrect. It probably needs to go back in the total reversal right into where it originated from. It needs to be reversed.
Have you represented anyone who has been subjected to a clawback?
Yes.
And what has happened eventually to the money?
So we haven't followed the paper trail. We have not followed. All we've received is, in fact, invoices or a claim by scheme level. We've not seen it in terms of that level of granularity, where, in fact, they're able to tell you which specific patient, which date claim, and where, in fact, the original claim was paid out of. So I think it is important that, in fact, that information be disclosed by funders. We also have, and this is anecdotal, and this is just could potentially just be insinuations, but we are advised that, in fact, a number of these forensics investigators are incentivized in terms of the monies that they're actually able to recover.
So just to go back to your previous point, if your argument is that the scheme must have suffered loss in order to trigger Section 59, why would the scheme then have to pay the money back to the beneficiary if the scheme is suffering the loss?
Well, we don't really know if it was the scheme where the loss was claimed, because in fact that calculation is done on a crude analysis of claims paid.
And I'm saying, I understand
Yes,
that
yes.
that's your factual submission, but in relation to the legal point, you argue that in order to trigger Section 59, the scheme must be able to show that it
there was
suffered
a
loss.
Yes.
Therefore, in order to fix that loss, they claw back or deduct. So why should they have to pay it back to the beneficiary?
In the instance where it is a true scheme loss, and I would argue that, in fact, if the original claim originated from a member savings account, it's not a scheme loss.
So you're also saying then that the scheme is not entitled to claw back when claims were paid out of member savings account.
Agreed. So, oh yes, I just wanted to clarify. My interpretation of direct payment as a sanction seems to be a little bit different. I think I got the feeling when I listened to one or two of these submissions made is that, and I want to explain my understanding, and I think the schemes would have to explain it a lot better, is that sometimes a tacit agreement exists between the scheme and the provider, and the provider is then paid directly for claims that are submitted. When a sanction is imposed, and they impose what they call a direct payment, what the scheme actually does in that instance is they pay the member directly. And then there's another definition, a further sanction is when they suspend the provider's practice totally, in which instance no claims are actually paid, not to the provider and not to the member. And then there's a further sanction, which is like, you must have really, really been a bad boy, and that is when they blacklist you. And in that instance, it opens up a whole other myriad of concerns, which is a scheme allowed to interfere in a patient's right to actually access services from a preferred provider that they have chosen? And what schemes are doing is that they're sending out communique, which I've asked for and I haven't yet received, by the way, to confirm, to referring practices to say, you're not allowed to use this particular allied healthcare professional going forward, because we will not honor any claim submitted by this particular healthcare professional. Now that blacklisting, in terms of the right to practice, the right of a patient to procure services, it just opens up a whole myriad of concerns and issues that I think have not been unpacked correctly, or to date, that I'm aware of. I think we spoke about the manner in which these investigations ought to be handled. It is my submission that, in fact, when there's not clear-cut fraud, when there are
Sorry,
issues
Advocate
around-
Hassim, I just wanted to, Hassim, I want to take you back to a point that you were made earlier, but on Section 59 and the loss, it has to be a specified amount. So you had mentioned the clawback that goes back over a period of time. How does that calculation of the amount over the period of time relate to the specific loss to the scheme?
So we don't really have that level of detail. All I do know is that when we are presented with the alleged losses, they are calculated at a line level. So it's the member and a claim. We don't really know from which pool, which bucket that particular claim actually originated from. It's just really at a code and a value level. And that's how they calculate it for a 3-year period. For every single patient that in fact that code may have been used. And that's how they calculate the clawback. So it's done retrospectively, and it's actually extrapolated from a subset of investigations that they've undertaken. But they do provide, in many instances, that spreadsheet. But what we can't see is the pool from which that payment was made, whether it came from a risk benefit or whether it came from a medical savings
Sure,
account.
but that's not my
Yeah.
question. My question is more about how the amount is specified, and whether it is specified. And you're saying there is a specification that is
Yes.
provided. You're given a
Yes.
spreadsheet
We've given a
of all.
spreadsheet. We showed how many times that code was used and how they've actually gone about the calculation for that period of time. It's my submission that in fact that fraud has to be distinguished clearly from waste and abuse as well, because I think it needs to be dealt with in a very different way. I think it would be advisable that in fact I'm hoping that one of the outcomes of this investigation will be that the trust relationship needs to be reestablished between funders and providers, and between the public, in fact, and providers. And in fact, there should be some sort of a remedial type of step where there's some form of consultation, there's some engagement, there's some remediation to assist with the issues around waste and abuse. Maybe not so much abuse, but waste. In many instances, services are provided because, in fact, at that particular point, the provider deemed that necessary. Or it was it could be defensive medicine. We know that the litigation is an issue. So the number of tests that are actually requested could well be in excess of what a funder may deem appropriate or necessary. But that type of engagement with providers needs to take place. When investigations and sanctions are undertaken, they should be in accordance with proper legal prescripts, which is they should be substantively and procedurally fair. There should be consistency in the manner in which these investigations are undertaken. There must be a level of certainty. You must know what the allegations are against you, almost like a charge sheet. There must be independence in adjudication. I think the chairperson alluded to that. Unbiased adjudication, not the funder deciding for themselves what is fraud, loss, or abuse. Proper representation, an opportunity to put a case forward. There should be an allowance for a time frame for pending investigation without a sanction being imposed. So if there is uncertainty, if there are issues around interpretation, allow the practice to at least be given a fair opportunity to resolve those issues before you apply a sanction, which often isn't done. There must be the fundamentals of evidence. There must be proof. I haven't had any experiences with the entrapment issue, so I'm not going to talk any further on that point, just to say that there were concerns around entrapment, where in fact these probes are sent out into practices. And then I do believe that there's an opportunity for conciliation, mediation, and arbitration in the manner in which these investigations and the sanctions are dealt with. I'm trying to think if that is my last slide. Yes, I think just in closing, I mentioned that I do believe that there should be a rekindling of the trust relationship between the various players in the sector, the industry.
The schemes have a legitimate concern in protecting their pool, the funds, because it is to the benefit of the members. And they have told us the billions that are lost to fraud, waste, and abuse. In the context of, it was 28 billion, I think Discovery spoke about. Well, what do you know about the amount that is lost, if anything?
So the 20% is, as you say, it's all of those, what they deem to be losses or unacceptable claims grouped together. If you unpack it into what is true fraud, and then the definition of what they deem to be abuse or waste has to be separated. The figure is not as high as that. I think the clear-cut fraud is much lower. A lot of these issues would not arise if there was clear understanding on how to actually use those codes and the proper billing. And so I don't believe that, in fact, the figure is as high as they suggest it is.
Okay, but even if it's not fraud, if there is over-servicing, that's also it doesn't work to the benefit of the members. So that's what results in the premiums increasing,
Yeah.
is the inflating cost of healthcare services. So even if it's not fraud,
Yeah.
the schemes still have a legitimate interest in curbing overservicing.
I agree that they have those concerns. I do think that they have to take a really good hard look at their own benefit design, which lends itself to hospice-centric care, which lends itself to overservicing, which lends itself to higher levels of care being provided, because that is what funders will pay for, as opposed to obtaining care at a much lower level, potentially out of hospital at a much lower cost. So by not, for example, paying for diagnostic procedures out of hospital, what you're inadvertently doing is you're driving admission rates. You're driving the utilization of a high acuity center of care, when in fact you could well be paying for a legitimate investigation in an outpatient basis without expecting a patient to dip into their own funds to pay for that service. So they really need to take a good hard look at their own benefit design, which in fact can't be separated from this systemic problem of why we see an increase in utilization. And if you look at the health market inquiry, that is not a logical explanation. The demographics of the scheme have not changed to such an extent that it actually justifies, well, I agree, I suppose you're saying, well, that's exactly their case, that the utilization should have gone up the way it has.
I mean, isn't that the true systemic issue, is that specialists in private hospitals are in a causal relationship with the schemes? I mean, that was one of the criticisms, and yet individual practitioners in outlying areas are systematically theft out and subjected to Section 59. If one is looking truly for what is the systemic explanation, that is the systemic explanation.
And the fact that there isn't enough benefit allocated to lower levels of care. I mean, the whole benefit design is geared towards specialist and hospital care. I don't know if I've answered your question. Yes.
What I did at the beginning, I didn't take your oath on the basis that you were an expert, but it became clear during the course of your evidence that although you have expertise, you are not an expert witness. So let's take the oath retrospectively.
Happy to do so.
What are you going to do, the oath or the affirmation?
The oath.
The oath, all right. Will you say then after me, I and your name,
I, Hassim,
do confirm
do confirm
that the evidence I have given
that the evidence that I have given
was the truth,
was the truth,
the whole truth,
the whole truth,
and nothing else but the
and
truth?
nothing else but the truth.
And then raise your right hand and say, so help me God.
So help me God.
And your attorney also spoke. And so let's take the oath for her as well. You will also take the oath of the...
That's correct.
Yes, all right. So will you say after me, I and your name,
I, Nabila Mula,
confirm that the evidence
confirm
I have
that
given
the evidence that I have given
was the truth,
was the truth,
the whole truth,
the whole truth,
and nothing else but the truth?
nothing else but the truth.
And raise your right hand and so say help me God.
So help me God.
Thank you very much. We will adjourn the hearing. This was meant to be the last of the schemes, sorry, not the schemes, the complainants and experts. But we received a request from, I think, BHF, that they want to offer an expert. We will consider the request. But the next sittings should now focus on schemes. We are trying to arrange that for the week of the 11th of November, the whole week of the 11th of November. We should be hearing from the schemes, but I think that there will be a notification from the Secretariat to that effect. The hearing is adjourned.